Welcome to Medical Logistics 101, right upper abdominal pain. Today we'll be talking about gallbladder disease. This video is for educational purposes only. It is not medical advice and does not replace a medical evaluation and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patient-centered healthcare with a map instead of a blindfold and to explain how clinicians think through these problems in resource-limited settings. Gallbladder disease. Some important definitions we need to get out of the way. Cholelithiasis. This is gallstones present in the gallbladder. No inflammation, no obstruction, no infection, often asymptomatic. Found incidentally on imaging. Oftentimes I'm doing a CT scan of the abdomen for other reasons, and these stones will be noted incidentally. Biliary colic. Transient obstruction of the cystic duct by a stone causes episodic right upper quadrant epigastric pain, often after fatty meals. Pain will usually resolve when the stone falls back into the gallbladder. These people will not have fever, they don't have elevated white count, and they don't have any peritoneal signs when you palpate their abdomen. Gallbladder disease continuing. Acute cholecystitis, a persistent cystic duct obstruction leading to gallbladder wall inflammation. Pain will last more than 4 to 6 hours, often severe and progressive. These patients may have fever, leukocytosis or elevated white count, and what's called a positive Murphy's sign, which I'll discuss in a minute. It can progress to gangrenous or perforated cholecystitis. Even more serious, cholangitis, infection of the biliary tree, usually from obstruction of the common bile duct. You can see what's called Charcot's triad, which is fever, jaundice, and right upper quadrant pain. And in combination with that, you can see Reynolds pentad, which is hypotension and altered mental state. A true emergency requiring antibiotics and biliary decompression, or ERCP, which I'll discuss in a minute. Signs, symptoms. Right upper quadrant or epigastric pain, often steady and lasting hours. Pain radiating to the right shoulder and back. Nausea and vomiting, fever or chills, but not always. Pain after fatty meals, anorexia. In elderly or diabetics, symptoms may be vague with minimal fever and atypical pain. Physical exam findings. Classically, right upper quadrant tenderness, guarding over the right upper quadrant of the abdomen. Murphy's sign, where the patient inhales while you are palpating the right upper quadrant, and they stop that inhalation because of a sudden onset of pain with that deep inspiration. More reliable when performed by the clinician than on self-exam. Low-grade fever, tachycardia, peritoneal signs, think gangrenous or perforated cholecystitis. Differential diagnosis mimics biliary colic, cholangitis, gallstone pancreatitis. These two things often go together. Peptic ulcer disease, gastritis, hepatitis, right lower lobe pneumonia. The beauty of that one is that I'll usually get a portable chest x-ray when the patient gets there, and I can exclude that right lower lobe pneumonia quickly. Appendicitis, especially a high-riding appendix. I don't see that often, but it is something to keep in the back of your mind. Differential diagnosis mimics renal colic or kidney stones on that side. Mesenteric ischemia, rare but dangerous. Don't see a lot of mesenteric ischemia, thankfully. It's a situation where you don't have adequate blood flow to a segment of the bowel. ACS or acute coronary syndrome, especially in diabetics or women. I get an EKG on patient arrival with these patients. Even though it's right upper quadrant pain, I get an EKG when the patient gets there. Diagnostics, labs. You see with a complete blood count, leukocytosis common but not required. Complete metabolic panel. Mild elevations in their liver enzymes, AST and LT, are possible. Elevated alkaline phosphatase or bilirubin suggests common bile duct involvement. A lipase, I usually get that just to help rule out pancreatitis. And a lactic acid if there's concern for sepsis or ischemia. Diagnostics, imaging, ultrasound, first line, bedside versus normal ultrasound, and availability issues. With the ultrasound, you're looking for gallstones, wall thickening, pericholecystic fluid, and what's called a sonographic Murphy's sign. Much like the physical exam, sometimes in the process of doing the ultrasound, you'll see what's called a positive Murphy's sign. And whoever's doing the ultrasound will usually comment on that in the report. On the ultrasound types, think of it as two broad categories, and I've covered this in other videos. You have the bedside ultrasound that the ER physician may use to look at mainly abdominal trauma patients, so-called FAST exams, as well as the abdominal aorta. And then you have regular ultrasound. For example, I've seen my primary care doctor. They sent me to the hospital for an outpatient ultrasound, and that's going to be ultimately read by the radiologist after a time delay. So it could be like the next day before we get the report back to my primary care doctor. The bedside ultrasound is typically not going to be read by a radiologist. That's just your clinician at your bedside looking in real time. And that might be the only ultrasound you have available in the middle of the night. CT abdomen and pelvis. And I say abdomen and pelvis because I generally don't order just purely a CT. If I order a CT abdomen, I'm ordering a CT of the pelvis. Useful when ultrasound is unavailable or equivocal. It's better for evaluating complications, gangrene, and perforation. Red flags that stand out: high fever and rigors, think cholangitis. Jaundice, think common bile duct obstruction. Hypertension or acute mental status changes, think Reynolds pentad. Severe diffuse abdominal pain, think perforation. Persistent tachycardia, elderly or diabetic patients with minimal symptoms but appear very sick. Elevated bilirubin or alkaline phosphatase, think common bile duct stone. Worsening pain despite analgesia. You treated them for their pain, their symptoms keep getting worse. Pitfalls: assuming normal labs, rule out cholecystitis. Mistaking biliary colic for cholecystitis. Missing cholangitis because the patient isn't jaundiced yet. Over-relying on CT when ultrasound is more specific. Though again, the problem is sometimes in the middle of the night, you may not have ultrasound. Not recognizing atypical presentations in elderly and diabetic patients. Discharging a patient with persistent right upper quadrant pain lasting more than 6 hours. Failing to consider gallstone pancreatitis. Assuming no Murphy's sign means no cholecystitis. Admission versus outpatient follow-up. Who needs admission? Confirmed acute cholecystitis obviously need admission. Fever, elevated white count, systemic symptoms, those would need admission. Persistent right upper quadrant pain greater than 6 hours. Elderly or diabetic patients with atypical symptoms or severe symptoms. Elevated bilirubin or alkaline phosphatase, which could suggest common bile duct involvement. Ultrasound is showing wall thickening and inflammatory changes, which would be the textbook definition of acute cholecystitis. Any concern for gangrenous or perforated cholecystitis. Gallstone pancreatitis. These people are going to be sicker than just a regular cholecystitis. Inability to tolerate PO with uncontrolled pain or vomiting. That's probably the most common reason. I can't completely get their symptoms relieved in the ER, and typically will be admitted, oftentimes to maybe the hospitalist, but then consulting the surgeon to evaluate them. Immunocompromised patients, because that would be a higher risk category, obviously. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.